Hi guys, and welcome back to the channel. In today's video I'm going to talk about a very important subject, and probably one of my favorite subjects in the clinical setting, and that's to talk about pain. I've been kind of seriously studying pain over the past two and a half years, and I'm only just beginning, I feel now, to get the grips of what actually pain is. Anyway, I heard a really good discussion last year where there was a couple of pain experts and pain scientists who were also runners, and they were talking about pain and running. And they outlined that about 90% of all marathon runners run with pain at some point, and that the main reason why any of them will come and seek help, either treatment or some sort of intervention to get over their pain, it's because the pain has interrupted their training schedule. So they're not coming because of the pain, they're coming because they can't train. And I just thought that was super interesting. So what I'm going to do today is just to briefly outline what pain is, and maybe clear up some little mistruths or some definitions that people believe to be true, but maybe holding you back in terms of recovery from pain if pain is something that you experience when you do run. So I'm going to begin with just reading what the actual definition of pain is. So if you Google what is pain, it will come up that it's some sort of a sensory feeling, an unpleasant sensory feeling. But in terms of definition, that's very untrue. So that's not exactly what pain is. So to give you the definition to start with, it's pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage. Pain is always a personal experience that is influenced to many degrees by biological, psychological, and social factors. So just to recap on that, the pain, like I said in that definition, pain can be caused by actual or potential tissue damage. So when we say potential tissue damage, that's where your brain is perceiving a threat, or it's perceiving that there's some sort of danger going on within the body, and it's perceiving that you might eventually get tissue damage, and that can cause pain. It doesn't have to be tissue damage. In fact, I would argue that the majority of people who are suffering with some sort of running injury or running pain or pain when they're running, they probably don't actually have any structural tissue damage. It's probably more of a sensitivity in the tissues that's driving that pain. For hundreds of years, we all, as humans and in the biological world, we had this model of looking at pain, which is called the biomedical model, which we now know is out of date. Since 1977, there was a scientist called George Engel. He put forward the biopsychosocial model of healthcare, which turned the whole belief about pain on its head. And it was only then that the scientific world started to realize that actually pain and tissue damage are not very well related at all. You can have tons and tons of pain and very little tissue damage, or you can have loads of tissue damage and not quite a lot of pain. So when you get pain, or when you think about pain, it's probably not very productive to think about it in terms of tissue damage, because, like I said, the two of them don't very closely go hand in hand, or they're not very closely related. Quite often in the discussions around running injuries or running type pain, or reasons why people can't run due to pain, people get confused about two different types of phenomena that are present and are happening in the body at a similar time. But clearing up that can definitely help you to get over some sort of running injuries or running pain. The first phenomenon is just the experience of pain. So pain is an experience, not a feeling. So you don't have any nerves in your body that carry pain from, say, your plantar fascia to your brain, or from your anterior knee to your brain, or from your hip. There are no nerves that bring that pain up. So the experience of pain, people usually talk about feeling pain, but you don't feel pain, you experience pain. And that's you quite often hear that when people talk about having a high or a low pain threshold. It's like that model of having a high or low threshold is kind of a little bit untrue, and it's because people's experience of pain are different. I could take 4 different people and subject them to the same stimulus, a painful stimulus, like an electric current, or make them hold a cold rod, and the 4 different people will experience pain differently. That's not to say that one has a higher threshold than the other. It's just that there's so many other factors going on in somebody's life that can lead to the amount of pain that they experience. So that's kind of the first phenomenon that we need to think about, is that pain is an experience, it's not a feeling. And the second thing is that feeling that you think is pain, it's not actually pain. What you get is a feeling of danger or threat going on in your tissues. So we have nerves in our body that carry a nerve signal called nociception, and nociception can be fired off because of a thermal threat, a chemical threat or a mechanical threat. So either of those, whether it's thermal, chemical, or mechanical, they can set off a group of electrical impulses coming along a nociceptive nerve, and then when those messages get to the brain, your brain then can, I suppose, in essence, decide whether it's dangerous enough or threatening enough for you to experience pain. And that's how we get into this kind of realm of some people thinking that it's tissue damage that's causing pain, but it's not. It's actually the tissues feeling that they're under threat or that there's danger going on, and those messages are getting sent up to the brain. And sometimes that's very true. So take, for instance, if you're out running and you kind of fall off the side of a curb, you might get some of those mechanoreceptors firing and telling the nociceptive nerves to send a message to the brain, because the ankle joint has opened up too much. You've kind of inverted or everted it way beyond kind of the normal biological entity of what the joint would do. Or you could be running and you're kind of doing a really hard session and you get a buildup of lactate and carbon dioxide in the muscles. When carbon dioxide is mixed with water, it makes a product called carbonic acid. So you get like a chemical imbalance in the muscles that, you know, that lactate and the carbonic acid can irritate those nociceptive nerves, and that can send up a message to the brain. That's definitely how we all experience pain when we run, for sure, especially if you're doing a hard session. So those sort of things can cause a nociceptive response, and then when it gets up to the brain can kind of think to itself, does this warrant enough for us to produce pain? And that's really how pain is set up. So if you have like a chronic long-term issue that's gone on, like I treat runners all the time, they've got grumbly backs or hip or anterior knee pain is probably the most, or maybe plantar pain. They'd probably be the two most common clinical presentation you get with somebody who runs a lot. And more often than not, when I explain to people, is that, you know, any tissue, like a broken bone, will heal after about 6 weeks. So if you have pain that's gone beyond 6 weeks, so you've had it for more than 6 weeks, the chances of it being driven by some sort of tissue damage are totally irrelevant, because tissues heal really well in that time. So if you have a lingering pain after that period of time, it's probably because you got some sort of sensitivity in the muscle. So there are biological factors that can promote or exacerbate some of those nociceptive messages that are going up to the brain, which then you are perceiving as pain. The first one is, if you've been experiencing pain for a long time, so say somebody's got like a plantar fascia problem, it's been going on for a long time, what can happen is those nociceptive nerves can biologically change a little bit. And where they used to send the message kind of at quite a slower rhythm or rate, it can get speeded up. So it just happens that some sort of sensory input coming down there, whether it's just getting out of bed in the morning and walk across the floor, that those sensory inputs just get elevated and elevated and elevated. And then you start to experience that as pain. For the want of a better word, it's like the muscles, or it's like I keep saying the muscle, it's like the tissues all around there, whether it's the muscles, the fascia, the bones, the capsule around the joints, the tendons, the synovial fluid in the joint. It's like all those tissues just get a little bit fed up, and the nociceptive nerves then just start firing way more, and then your brain just interprets that it's much more of a threat now than what you would usually experience as a threat, and therefore you experience some sort of pain. The chances of anything that's been there for 6 weeks or longer being some sort of a tissue damage, or when we say plantar fasciitis, that would give the implication that there's some sort of inflammation in the plantar fascia. But if that was true, just taking some ibuprofen, which is an anti-inflammatory, should clear that up pretty well. But invariably it doesn't, because 9 times out of 10 or 99 times out of 100, there is no inflammation going on with a plantar fascia problem. The next thing that can happen in terms of a biological change is you can get these little stress receptors that start to build along the nerve. So they can cause the nerve to fire off a lot easier, and they're the kind of person that, you know, even to touch the area that's sore, it becomes very painful with just a very light stimulus. And that's when you get that building in, that's the beginning of a road down a condition that we call chronic pain. So chronic pain is something that's been there for probably 3 to 6 months, and then longer than that. So if you've got pain for over 3 to 6 months, then you're kind of, this is what's happening. You're getting these stress receptors built up along the nerve, and now the nervous system now is the problem. It's not actually the musculoskeletal system per se. It's more a nervous system problem if that pain has been there for that long. The third thing that can happen then along that biological front is that the messages are not only going quicker up and down those nociceptive nerves, so happening at a faster rate, but also now the signal is much more amplified. So when what you would usually take, say, somebody with some anterior knee pain that's been there for a couple of months, and they're beginning to think that it's osteoarthritis or something, so they start to catastrophize things in their brain. And then when they do get some sort of a stimulus, so even just going for a walk, so putting some stimulus through the mechanoreceptors in the joint or around any of those sort of thermo or chemical receptors, a small little bit of sensory input along that can send a very large message up to the brain. So now it's going faster, but it can also be a much more amplified message, and that can really start to bring you down that route where you're in kind of big trouble now, because that sort of pain, once you get to that sort of region of pain, that's very difficult to overcome. It is definitely worth seeking to get some sort of professional advice from somebody like an osteopath, physio, physical therapist, chiropractor, whatever it is you go to see. But I would make sure that whoever that person is you're going to see has some sort of training or has some sort of experience in dealing with chronic pain or pain specific. You know, somebody telling you that you're out of alignment or you need to be cracked or fixed or something back into it, that can become very dangerous in a sort of position where somebody who's in chronic pain. I see this quite a lot in clinic, as people coming in saying that they've got an out of place pelvis or they're twisted or their alignment's off, and you know, that sort of stuff. Putting those sort of beliefs in somebody's brain can, like we said before, add to that biological change that can amplify some of those nociceptive messages coming up the nervous system into the brain. So like I said, that's a real nervous system thing that we need to deal with, not so much a mechanical musculoskeletal thing. So any sort of psychological factors as well going on in your life, that can also bring up the nociceptive pain sensor. So any sort of stress that you're experiencing, psychological stress, again, that's going to bombard that nervous system. And if the nervous system is already under threat, say it's got a sensitized area like the plantar fascia or the anterior knee or the hip, if it's already under a little bit of stress and then you start to add in some real psychological stress, that can really amplify that pain as well. So that's something to look out for if you have a running injury and you're struggling with injury or struggling with recovering from injury or pain, should I say. Having some psychological stress in your life, it's just going to amplify that. So that's definitely something that you need to look out for. And then the last thing to say in that would just be the social aspects as well. So if your injury or your pain is going to threat your social injury, say you go running with your clubs, you meet with them on a Tuesday night and you go running, you meet some friends, you have a bit of a chat, and then maybe you go for a long run on a Saturday, and then when you finish that, you go and have coffee with them, or you do a park run, and when you finish the park run, a couple of people meet up and you just go and have a coffee and a chat. Taking that away is another big factor into how we know pain manifests itself in the body. So I would always tell the people who I treat, runners, triathletes, cyclists, swimmers, that if they are in pain and they are injured and they're out of training for a couple of weeks, if they can meet up with the group and go for those coffees or have a chat, or if there's a long ride and you meet the guys afterwards, those sort of things are really, really important to keep those social interactions at play. If you take those away, your chances of recovery from pain diminish very, very quickly, and your outcomes become a lot less. Anyway, that's just kind of a brief synopsis on some of the stuff that I've learned over the last couple of years studying pain in some detail. I hope you enjoyed that. Please, if you have any questions about this, pop them below. I'm thinking about doing a live interaction where I could maybe get people to post questions and then I could discuss them online and people could go, jump on a comment. If that's something you think would be helpful, please leave a message below and let me know that you think it would be helpful. I hope you enjoyed that. I'm not going to rabbit on too much because I'm just aware that this video could get a little bit too long. So anyway, remember guys, run far, run fast, but most of all, run sensible.